Hello, how are you doing?
I'm doing wonderful. Thank you so much for having me today.
Oh, I'm so excited to talk to you. It's so interesting to talk to someone on the integrative side who's worked for big bad pharma. And I'm
Oh, I know.
kind of
I've been on the
joking.
dark side, and now I'm the angel on the other side too.
When I was reading your bio, I was thinking, I'd like to go work for a company sort of like as an implant or whatever you call it, just to see how everything works. It would be really cool. I should have done that in my journalism career when I was
Oh
younger.
my
I should
gosh,
have
yeah.
gone deep.
And it's really
Because
interesting when you get behind the scenes, especially of a big, huge consumer company and how cutthroat it can be. And although they always put out these altruistic tenets, the way they treat their staff sometimes isn't always necessarily that great, or it's highly competitive. So
interesting. Yeah, they
yeah.
probably work you really, really hard. I
Oh
mean, you
yeah.
make good
Well,
money, but
it's so funny too. It's like when you work at companies like Procter and Gamble or J&J and all the biggies. And I'm not saying that it's this way everywhere. And a lot of it's manager dependent, but there's always that thing you have to prove you're working at 3 a.m. and doing that so that you can show your dedication that you're willing to be available 24/7 at ridiculous requests. And I mean, I even remember I had ankle surgery and I was in a cast for a period of time. And a week after it, I was knocked out on Vicodin because I was in so much pain, but yet I'm on a plane going to speak at an event because I felt I needed to. So it's ridiculous.
once you start your own thing, it seems really inconceivable that you did that,
Oh,
right?
I know.
Like,
I'm like, what was I thinking? I should have just said, what are you thinking? Why are you asking me this? No.
right. And then when you start up, like, as you have your own clinics, like, it's so much work.
Yeah.
You just think, well, why didn't I just do this work for myself rather than for someone?
Yeah, exactly.
Someone,
I always say if I'm going to work for an asshole, it's going to be myself.
yeah. What we always hear, like, I don't know whether did you sign an NDA, like what can you talk about? Like you hear inside that it was a very male-centric conversation and there was a lot of joking. I've heard that from people who've worked in pharmaceutical companies.
Yeah, I think to some degree, I have to say Procter Gamble at the time was actually not that way. I mean, obviously there's a lot of male dominance in the leadership roles, but in our particular group, since we were focused on women's health, there was a lot of female providers. I mean, ironically, here they were launching a pharmaceutical company and a big, huge corporation, and they had very few doctors actually working. They were more PhDs and various things, but there was actually quite a few women in some leadership positions. So it wasn't, I mean, but there was definitely the sexual harassment issues and some of the things that you just put up with. I mean, unfortunately, and I know that I personally was dealing with some stuff there, but you know, it is what it is. Times have changed. So that's half the stuff that we had to put up with wouldn't happen now. So,
Well, you didn't even know it. Like,
I didn't
sorry?
even know it was a problem.
No, you didn't. I did an internship at a TV station and the guy who covered the health beat, they called him the doctor and he called himself the doctor. Like it was a joke. But I sat near a bunch of guys as the intern and they were really super sexual. And I think I was laughing and being cool because I wanted a job there. Right. And I remember the second time I came in, they're like, oh, she's really cool. And then they just started, it was more and more. And then I was sitting there going like, I feel sick.
Yeah, you want
But
to go
when I think about
sour.
that moment, I didn't think it was harassment. I was just like, oh, this is too much. Like,
Yeah. Well, and what I
this is,
found really interesting too back then, that people did speak up. Like if a woman was witnessed different things or even was asked to comment if they were investigating different things, no one wanted to go out on that limb and stand up for other people. And I just, that part was the part that bothered me the most when I saw it going up.
yeah. And now when people are like, why didn't she say it? It's like, I worked in places you would never say anything. You would have a terrible time. Your career would be
Yeah.
derailed
Oh,
instantly.
completely. I saw one person in particular, her career was completely killed.
So what drugs did you work on developing?
Yeah, so when we were there, I was responsible. So it was interesting. Procter and Gamble notoriously wasn't involved in pharmaceuticals, and then they decided to get this bright idea they were going to go do this. And it was kind of an experiment for them. And they ended up hiring 8 medical directors across the country. I was hired closely out of my residency to be their West Coast medical director because of my specialty interest in women's health. And they asked us to work on Actino, which is now so they have Actino, which was the osteoporosis drug, and then also Intrinsa, which was the female testosterone patch. So it was really, for me, it was a really great opportunity, not only to learn a lot about those specific product lines and the products themselves, but it opened the door to meeting some of the brightest and most experienced international experts in these topics. And I was just like a sponge learning from all of them. It was really an amazing experience, but unfortunately, Procter and Gamble was a fabulous consumer company, But unfortunately, it doesn't always parlay into the medical space, because I think you can get a bit of arrogance when you're number one in the consumer space, but when you transition, you're expecting physicians and practitioners to respond as the average consumer, where they're learned intermediaries, and it didn't quite go. And I think there was also some, obviously the FDA became problematic when we were trying to get our female testosterone product launched. And we failed miserably here in the US, but we're able to obtain it outside of the United States for Intrinsa. But it was one of those things of the perfect storm of bad timing. Here we had a testosterone patch for women. It had the cleanest data set I've ever seen out of any research project. And we had all these randomized controlled studies. It was highly powered, like hundreds of women. It was fantastic. But the Vioxx scandal happened, which for those of you know, that Vioxx is a medication used to treat like joint pains and aches, but then they had some problems with cardiovascular things and they had to withdraw the drug or at least limit it. And then they had the Women's Health Initiative right on the heels of that, which then scared everybody. So the FDA didn't want to approve anything that even potentially had some risk associated with it. So they shut it down here in the US. And then Procter Gamble soon after that kind of had to, they made the call to say, you know, we're really going to get out of pharma. So.
It's expensive. So that was 2000, because was it 2004 that Intrinsa was not approved by the FDA?
It was right around that time, 2003,
Yeah.
2004. Yeah, it was really horrible because, and in my opinion, it's just always so amazing to me, the gender bias that occurs, because here you had Viagra and testosterone, even the injections, they have, most of those products have very little data and research on them. These products can not the testosterone for men, but say Viagra can kill men. But God forbid we get some chin here and we have all these randomized controlled studies and highly powered things, and we can't even get one product approved where everything they get gets pushed through immediately, even if it's going to hurt them. So, I mean, it's absolutely, it's maddening when you actually stick back and think what we have to put up with.
So how much of it, because when you hear people say, oh, like it wasn't approved, how much of it was sort of like sexism?
Well, I think there's this a feeling of lack of importance for those hormones in women, even amongst OB-GYNs and general medical professionals, because that's what we've been taught. And even when you look at current medical school training, since the WHI horrible study report and everything that they badly slaughtered in the media, they just dismissed all that stuff from medical school. So it's not even deemed warranted enough to where you need to be educated on it, let alone to understand the treatments. And it just never ceases to amaze me is that so just to give you an example, testosterone is the most abundant hormone that women make, but it's completely ignored. They think, okay, well, it's there, but you know, we're not going to do anything about it. So everyone keeps focusing on estrogen with us, but we're more than that. Men actually make estrogen in addition to their testosterone, although it's very, very little. But testosterone deficiency in men and women presents exactly the same, other than we don't get the visible effects of erectile dysfunction, but we get low libido and lack of desire, but it leads to weight gain in both men and women, insulin resistance in men and women, mood disorders in men and women, executive function. I could go on the things it causes, but it presents exactly the same. But a man walks into a medical office and talks about it. He's going to get his erectile dysfunction drugs and he's going to get testosterone. A woman walks in, we're going to get put on an antidepressant or deemed we have fibromyalgia. And here's your SSRI, go and get biochemical counseling or go on a date night and reduce your stress. I mean, it's obscene how different we're managed and treated.
But even if you find a doctor who's going to prescribe you hormone therapy, oftentimes, like you said, the focus is always on estrogen. I find that so, first of all, I never knew that we made more testosterone than estrogen. Like everyone who's a woman thinks that they make more estrogen because that's all anyone ever talks about. And I first was interested in the obsessive focus on estrogen when I talked to Dr. Jerry Lynn Pryor, who's a progesterone person. And then I started thinking, why? Because so many doctors I interview, I ask them about progesterone and it's just like this, like, it's just like, they just give it because they have to, basically, if you have uterus. That's how I feel. But testosterone is like, but testosterone is even like, not even in the conversation. It's not even like, how has this happened that it's the most abundant hormone?
Is it lack of education and propagation of misinformation, and it's the dismissal of what's important in symptomology and truly understanding a hormonal milieu of a female patient. So for instance, when people talk about women and all they want to do is get rid of our hot flashes and help us sleep better. And oh, by the way, make sure that we're comfortable if we have sex. So those are really the focus, and those are the estrogen symptoms, but everyone seems to forget the other side of that, as you say, the testosterone, which in my opinion is actually, I mean, it's equally, but it may be a smidge more important when you look at chronic disease state development. So for instance, so estrogen affects the hot flashes, the night sweats, the mood swings, and now they're seeing this really wonderful data about its ability to prevent cognitive disorders down the road, and women who have actually more severe hot flashes and don't get treated are actually going to have more likelihood of Alzheimer's or dementias. But estrogen also affects our endothelium, so the inside of our blood vessels. And when you lose your estrogen, your arteries start to harden and crack and have plaques, which leads to hypertension and problems with heart disease and heart attacks. It also affects our bone health. But if you want to flip it to the testosterone side, obviously we talk about the libido aspects, but it's Mother Nature serotonin, so it affects our mood. So we lead to panic, new onset depressions, apathy, number one, but most of our serotonin's in the gut, so it leads to IBS symptomology. But when you start talking about executive function, thinking and all these other things, but its main job, in my opinion, as an internist, is it affects glucose metabolism. So if you eat a meal, everything converts to sugar. It has to, and sugar is needed for our body to use as energy. But it's testosterone's job to move it and facilitate its role into the muscle so it can burn cleanly as clean energy. When we lose our testosterone, that doesn't facilitate any further as effectively, so you develop what we call insulin resistance. So the pancreas has to use more insulin, which then takes that sugar and stores it as fat, but then also it burns the pancreas out, so which leads to insulin resistance. And we continue this pathway where we gain weight, we become more insulin resistant. Everybody wants to put us on metformin or all these, I know the big crazes are all these diabetic drugs for weight, but you're not addressing the underlying root cause, which is testosterone. And it explains why biologically men do better than us when it comes to weight, because they have more testosterone and they have more muscle. We are already biologically set up against it. So if we go down that path, the next thing you know, we're morbidly obese, we're developing diabetes at an obscene rate in this country, and then all the cardiovascular events that come from that. And nobody wants to seem to address that. And instead they give us these drugs that actually make matters worse. And it just doesn't make sense to me. And why it's ignored in women makes, and it actually makes me infuriated. So, but you have to temper.
Well, it's an insane gap. Like it's right there in front of everyone and it's just staring. So what's the ideal approach then? The combination of this sort of like,
well, so since testosterone is our most abundant hormone, we actually need more of it than we need estrogen actually day to day. And what's also interesting is testosterone is kind of like using cash. Once you spend it, it's gone. So it doesn't store anywhere in our body. So when we make it or give it, it uses it and then it just goes away. Estrogen is a little more savvy. It's kind of like a savings account. It stores in our fat. So we actually, because we make less of it and because we store it, we need a much less amount of estrogen than we do testosterone. But I see all the time in clinical practice, in particular OB-GYN, they just put women on all these horribly high doses of estrogen. Next thing you know, their boobs are going to blow up, they're bleeding, they're bloated, they're gaining weight. It's because they're not understanding that true balance and how it biologically works. So it's really imperative to do a whole bunch of testosterone, a little bit of estrogen, and if a woman has a uterus menopausally, protecting the estrogen from causing too much of a uterine line buildup, which can lead to cancer, that you have to use progesterone to balance that. So that's really the proper balance. And then, oh, by the way, in the middle of perimenopause and all this, a lot of women develop thyroid disorders, which just compounds everything. So.
Well, that's funny that you say that because I just found out I have thyroid antibodies and I have to get to the bottom of all that. I'm not on HRT because I have a gynecologist who doesn't want to prescribe it. She's from India. So I'm sorting it out and finding someone. But yeah, how does thyroid throw everything? Does the thyroid develop sometimes because of the hormone issues that are going on?
No, they're like best friends. Like testosterone, estrogen, and thyroid are like the three musketeers. They play together, they work together, they help one another function. So when you have that, yeah, I call it the axis of evil. If one of them's off, the others are going to be affected. And yeah, so, but it's really interesting is thyroid is really imperative to our overall endocrine system. And it's really just a big symphony running around working together. And if one's off, the whole thing sucks, you know what I mean? So but thyroid's fascinating. And as women get older, we become less and less efficient in our thyroid, just like we do with our ovaries. In particular, more now because there's so many endocrine disruptors in society and all the environmental crap, God knows what's in our water and those things. But thyroid, think of thyroid as the engine of your body. And if your thyroid slows down, the whole engine slows down. So that's why we get fatigued, we gain weight, our hair starts to fall out, we get cold, we get constipated. It's just everything goes to slow. So then if you compound that with the testosterone and estrogen deficiencies, these women come in and they feel like crap. And it's like, no wonder. I mean, hello, your engine's slow. You can't metabolize sugar well. You're not sleeping. And I mean, how can you possibly function? But women are very stoic. And our grandmothers used to take Xanax all the time to deal with it or drink, you know. I mean, but it's important that you fix them together. Because when women come in, they always say, well, can we do just one at a time? Ideally, you want to fix the whole system simultaneously. But if they don't want to do that, then you always should start with thyroid first and then fix the others. And the reason being is, let's say because thyroid and testosterone in particular affect one or each other very intimately. But what's interesting is if I fix the thyroid first, testosterone doesn't change. It just kind of stays where it goes. But if I fix testosterone first, it could affect how thyroid functions. And 80% of the time it gets better, but 20% of the time it gets worse. So I'm always better starting with thyroid, because if I start with testosterone, they feel worse. So I go, what are you doing, doctor? You don't know what the hell you're doing, meaning that because now I feel worse. So I always feel, and thyroid is really essential.
And when you add the testosterone, does that help with the insulin resistance just on its own?
Absolutely. So when you, in particular, I specialize in hormone pellets, which are, they look like little Tic Tacs, but they're pure hormones and they go under the skin in the buttock region and they do a slow release. Because you have such an even steady state with that delivery system, that one works most effectively for insulin and the glucose metabolism. So there's a marker that we use as physicians called hemoglobin A1C. So if I were, which assesses overall glucose control. So let's say today I drew your blood and I checked your sugar. That's a snapshot. It's going to tell me what your sugar is at that exact moment in time. The hemoglobin A1C is a movie. It tells me what your trends of your sugars are over, say, a 3-month period in your red blood cells. So it's more reliable, because patients come in and say, oh, I'm watching my sugar, and you check it for that day and it looks good, but you look at their movie and they're going, wow, you really have not been watching your sugars. So that hemoglobin A1C is really important for us to check for screening for diabetes, insulin resistance. A value under 5.7 is normal. So 5.7 up to 6.4 is insulin resistance or prediabetes. And then over 6.4, it's diabetes. You will often see as women move into the perimenopause and they start to lose their testosterone, they start to develop that insulin resistance. So it's not uncommon for us to see hemoglobin A1Cs of 5.9, 6, 6.1. But within 1 month of me putting women on testosterone pellets, I often see that normalize. And I see it all the time. And it's biologically doing what it's supposed to do. And then when that corrects, women now can process sugar more effectively and start to reestablish normal weights and those things, which take about 3 to 6 months. But assuming they're not eating cheeseburgers every day, all the efforts that they put in now should work, in particular if we get their thyroid fixed.
And thyroid pellets are one of those really, really divisive things. Like when you look at social media and there's doctors saying, if your doctor suggests thyroid pellets, leave. It's terrible.
Are you referring to testosterone pellets? Or
testosterone, yeah, sorry, not thyroid pellets. That would be,
for the audience.
yeah, sorry, I invented
I'm like,
something.
that would be really cool if we had thyroid pellets. We don't.
No, testosterone pellets.
An interesting idea.
It is. Maybe you can go back to pharma and help develop it. Testosterone pellets, yeah, they're so divisive and it's really hard to get a read, because I'll look at some doctor talking about them and saying, geez, those sound terrible. And then I'll talk to someone who's taking them and loves them, talk to someone who prescribes them like yourself. So what issue? Is it like their private?
It's a lack of understanding, because the people who are poo-pooing it, really, if you start to dig in, they really just don't understand the data. And what they're seeing is they see high levels of testosterone in women when they draw blood work, and they don't, And first off, if doctors haven't really studied hormonal medicine, they're just relying on a reference range. They clearly don't understand hormonal medicine. And the reference range has notoriously been wrong, but also when you look over the data over the last 60 years, and mind you, pellets have been out since the 40s. And they're a very, very clean, pristine, most biologically similar delivery mechanism out of any of them. But the issue that other folks have is when you put pellets in a patient, we drive testosterone levels up over that reference range, which makes a lot of people crazy. And they go, well, that's not normal. But the problem is serum blood levels of testosterone have never correlated very well to actual clinical effect. So for instance, let's say the reference range goes up to 70 in women. Oftentimes with pellets, you have to drive levels to 150 to 200. And that's considered an average. So there's other practitioners that go higher than me, but that's kind of what I'm averaging, 2 to 3 times the reference range. But when you look at the pharmacology of pellets over the last 60 years, that's actually a decent level to obtain, not what the blood level is in the serum, but actually to have clinical effect at the cellular level. And a lot of medicine doesn't address cellular effect. So we look at serum levels, but I could flood, let's say your system with testosterone, but if it doesn't get into the cells, it doesn't matter. So the way to really assess patients is to use those blood levels as a guide, but until we can actually measure cell level effect, what we really need to look at is clinical symptom improvement. So I want to look for all the symptoms improving without side effects. So if you get a plucking of a chin hair here and there, that's okay. But if you have a fulminant beard, that is not okay. So we want to watch for lack of side effect. We want to make sure we have clinical effect, and we want to see the blood levels improve. So it's really that lack of understanding of the clinical data related to clinical correlation in women. And there's also the testing mechanisms are much less reliable, because in men, their whole system, they have 10 times the testosterone we do. So the systems are easier to measure that, but in women, it's less reliable. But again, it doesn't correlate to clinical effects. So we treat patients the way we should. And even when you look at like some of the more conservative societies, like the obstetrics and gynecology societies, they even in their printed guidelines, so we shouldn't be following levels. We should be looking at patient clinical effects. But when it comes to testosterone, they seem to ignore that. You know what I mean? But with estrogen, they're fine with that. So it's a complete lack of understanding of what testosterone's role is. It's a lack of understanding of how to properly interpret the references and reference ranges and how to properly treat. So if people say that, it tells me they don't get it.
Yeah. Well, there's a lot of people speaking very authoritatively about things they don't really
That's why
understand.
whenever I can get in arguments with physicians all the time, I said, until you go study this for 25 years, I can quote you all the data. I know all of this. This is what I've studied intimately for 25 years. And you probably say you've looked at a book or maybe read a little article or blip. Let's go to it, because I'll give you the data. That makes me angry when they say there's no data. I said, absolutely, there's tons of data. You've just chosen not to look at it. So
I guess the fact that you put them in and they're there for what, 6 months? That's sort of a bit of the issue.
Well, it depends. So women typically they're in 3 to 4 months. And here's always been the concern is like, once they're in, you can't take them out. I mean, you can, but it requires a little surgical procedure and nobody wants to do that. So here's the risk. So let's say we put them in and for some reason the patient doesn't want them. I mean, they're in now for 3 to 4 months. You're committing to that. The biggest concern is, well, what if I have a bad reaction to that? Well, so this is why it really is dependent on making sure you know who's doing what and going to the right people. Because if you have one of those practitioners who hasn't properly trained, and the next thing you know, they flood your system with estrogen and give you an outrageous dose. And I've seen this all the time. So the average doses of pellets are somewhere between 6 and 15 milligrams. Some of these people who don't train or know what they're doing, they give 50 to 100 milligrams. Those patients are going to feel horrible. So it's really important to know who you're going to, or if they don't give you enough testosterone or none, it doesn't balance. So I'm always giving what I always tell patients, I need to be ultra conservative with estrogen in you, because if I get into trouble and overdo it, it's going to take a while to get out because it stores in your fat. So I'm going to always go under where I think you should be and kind of titrate up. Testosterone, on the other hand, as I said, we use it immediately, it goes away. So we don't store it. So I can be more aggressive. And frankly, since it's our much more abundant hormone, I want to be more aggressive there. So when we place the pellets in, 1 month later, the levels are going to peak. Excuse me. And I always check blood levels at 4 weeks. Now, if I'm going to get you into trouble, which most would say 85% of the time, I nail the dose right out of the gate. But I've been doing this a long time. I'm really good at figuring this out. There's about 10% that I'm going to underdo it, and there's going to be 5% that I overdo it. Now, if I overdo it, it's transient with testosterone because you hit that peak and quickly, if I do nothing, it's going to come back down, and within 2 to 3 weeks after that peak, it should be out of your system. And you may only experience major side effects at that peak for about a week. We can manage through that. Some women, if you can just, and the side effects, maybe you feel extra, really like super hypersexual, which most people don't seem to mind, but they may get some acne, they may be aggressive, angry, irritable. But most often people think testosterone makes you aggressive, but when it's done right, it actually makes us happy because it singles all that serotonin. But it's a week that we could get into trouble. And if it's really bad, I have medications to block it, which I reserve in my back pocket if I need them, but I've only had to use them 3 times in 25 years. So it's really important to get with the right people, because if they do it wrong, you could feel badly.
What about vaginally? Because we only hear about vaginal estrogen, but I know you can use testosterone.
Vaginal estrogen, vaginal progesterone, all of them. I just don't think it's a good delivery mechanism, and it's also really messy. So when I look at my universe of hormones, pellets are my gold standard because it's most consistent with what our bodies do already, and it gives you a very even steady state. Creams and gels, we can put them on our wrist, bikini line, behind the knee, any thin surface. They're okay, but they only work, the efficacy of those are maybe 20-25%. I'm being generous, so they only work a little bit. But also you risk transferring those cream doses to your grandkids or your animals if you have them, or even partners. My next phase, if I can't do hormone pellets in women, I will generally then go to what's called a fast burst sublingual, or some people call them oral dissolving tablets or rapid dissolve tablets, which really go under the tongue and absorb through the mucosa under the tongue. And those I get about a 40%, maybe 50% efficacy. But in women, the pellets are like color TV, where everything else is black and white TV. They work, they're just not as vibrant. So
I asked about vaginal testosterone because there was a nurse practitioner who presented to the North American Menopause Society a couple of years ago about using vaginal estrogen, and I interviewed her, and she was saying there's testosterone receptors there, and when you apply it directly, it can bring them back to life. And she talked about muted and disappearing orgasms, which I hear women complain about. I've experienced it myself, and it's like upsetting, right? So I wondered what does testosterone do for that? And do you need to put it on your vagina to make it work?
No. And what's interesting is there are definitely testosterone receptors in the vaginal wall, but there are none in the uterine wall. But the testosterone, when you look at libido, orgasmic response, the ability to achieve orgasm, and also the magnitude of that, is really a testosterone effect. And then estrogen's really vaginally there to make it a nice environment for penetration. So that's more pain and lubrication. But testosterone is essential for all those other nice effects from having sex. So you need to get enough into the system to drive, number one, desire, which is at the brain level. And then having that orgasmic, it's really a neuroendocrine kind of firing. So it's really the systemic testosterone. You can deliver testosterone there locally, but if you don't fix the systemic component, it's not going to fire as easily. So I just find I can kill 2 birds with 1 stone by using the pellets and not have to do something vaginally.
Okay. So all that stuff would get better too if you took it.
Yeah, absolutely.
Okay. What about, we're hearing a lot about prevention. Obviously the literature is, with osteoporosis, it's really clear. But there's a lot of people talking about take hormone therapy to prevent this, to prevent that, all-cause mortality. There's studies. If you don't want to, or you can't, do you have to worry? Like, if you're living a healthy lifestyle, in your opinion, like, is it, is there other ways to have a healthy, long life?
Well,
you have to take hormones. It's starting to feel like you have to take them, or you're going to be decrepit.
In my opinion, that they're an essential component to longevity and aging, or preventing accelerated aging. Not to say that someone who doesn't take hormones can't live a long, healthy life, but let's talk about the quality of that life. Oftentimes, and women are living a long time now in menopause, and we want to be vibrant and healthy during that time. Some people always argue with me saying, well, isn't menopause a natural state of affairs? Why are we fighting Mother Nature? Well, there's the way I kind of look at it is this. Number one, the main reason Mother Nature shuts down our ovaries in the 50s is Mother Nature doesn't want us to get pregnant well after that, because God forbid we have children at 70. We wouldn't live to take care of them, and we wouldn't have the energy to do so. So biologically, it makes sense to shut the ovary down at that age. However, there's this indirect consequence of doing so, because then you lose the vital hormones that keep us vital and healthy and alive and functioning really effectively. If you don't take hormones, you can certainly eating right and be having, let's say, plant-based diets or Mediterranean diets or all those wonderful things have clearly shown that it has positive effects on the body. Exercising, doing all those things are very, very helpful for longevity, but doing those things cannot overcome hormone deficiencies, which will take place. If you're eating right and getting all those things in your diet, could you delay the onset of osteoporosis? Probably a little bit, because it's a vital part. If you're getting vitamin D or calcium, you're eating all the things that you should, or you have good genetics, you might be able to get past that. But at some point, you're going to break some bones because you don't have the proper structure that was being held together by estrogen and testosterone, because estrogen prevents bone loss. Testosterone lays bone down, which is why most men don't get osteoporosis unless they have secondary factors like smoking, steroids, or various other things. But it's going to happen at some point. And the question is, it's a risk benefit ratio. What's your risk tolerance? Because you could be a marathon runner and doing all these wonderful things, but if your bones are breaking down at an extreme rate because you haven't gone on hormones, you're putting yourself at greater risk of problems.
What about risks of testosterone? I don't hear much about those.
Well, it's interesting when you talk about testosterone, everybody thinks that we're going to become jacked up men, and we're going to have beards, and we're going to get aggressive and beat people. Again, they don't understand. Women actually make already a lot of testosterone. So the risks are, let's say I were to overdo it. So I differentiate between side effects and adverse events. Most of the time I will tolerate in my patients a little bit of side effects as long as they're okay with it. So if you get a little bit more chin hair growth, and then if you want to keep your levels a little higher, I'm fine with that. But then you may have to go wax or laser or do those different things. But if it's a fulminant beard, then it means I'm really in a area that I shouldn't be at. The levels are way too high. Some people get a little bit of acne, in particular when we start it, because we're kind of essentially putting you back into puberty again. But if you have acne all over your face, all over your back, that's a huge problem. We shouldn't be doing that levels to that degree. Now, if I keep going and I give you exposed levels of testosterone for long periods of time, you could then develop clitoral enlargement, which it's going to enlarge a little bit even at normal levels, because if you've already gone through a menopause, everything shrinks, including the clitoris. So when I reestablish, it will get a little bit larger, but we don't want little mini penises. So that's a problem. Voice deepening can occur. Now, I know there's some literature to suggest that doesn't happen. I've seen it happen clinically. And you can get lipid problems and various other things. But the goal of treating women shouldn't be going into those areas. We need to make sure we keep them at proper levels where they're minimized side effects to no side effects whatsoever. And again, it comes down to really monitoring your patients to make sure you're doing it properly, not pushing it too hard.
Okay. And I'm curious, asking you about this new drug that appears imminent from Astellas Pharma called Fazolitant. It was the subject. Well, the company paid for the Super Bowl ad. The first time menopause went to the Super Bowl. But you didn't see the name
Menopause has been to the Super Bowl for a long, long time with all the women attending, but it's the first time they made it visible.
I love the stat. I was reading about it, and they said 100 million people watch the Super Bowl, and 17 million of those are, half of them are women, and 17 million of those are women between 35 and 65. So like hot flash territory. It was really cool to see those stats. But so anyway, their commercial was about hot flashes, but it's a marketing campaign for a drug that they're expecting to come get FDA approval, Fazolitant. So I wonder what you thought about that drug, a non-hormonal therapy for hot flashes. The first one, I think, that will be in the market. What's your take on it?
Well, what my take on that is that once again, they're giving us a drug that is a brain altering medication to treat a specific or a couple specific symptoms of menopause. They're not addressing the whole patient. So let me break this down a little further. So number one, first and foremost, I am glad to see those kind of commercials on it because all ships rise with tides rising. You know what I mean? So it's going to bring more exposure to the whole market, which is good. The problem is it continues to send this message that women are all about hot flashes. And that's all we're really concerned about when it comes to menopause or their sleep or vaginal dryness, which I think are all wonderful things and we need to address them, but it's only a minor component of the whole menopausal syndrome and all the chronic disease state risk that develops from that. So, and it also disturbs me that they continue to develop drugs that affect our brain chemistry. I mean, you look at the drug that got approved for female sexual dysfunction, it's really kind of on the range of antidepressant. I mean, why do we continue to need brain medications to treat symptoms of something that could be easily and cheaply addressed with hormone balance in patients? Now, excuse me, not to say that there may not be a small group of patients that could benefit from that, in my opinion, because the majority of the patients I can go ahead and treat with hormones and get the effects that I'm looking for. I don't need those drugs. But let's say I have a patient who's had or is undergoing active breast cancer. I can always put women on with active breast cancer or a history of testosterone, because actually testosterone is good for the breast. It lowers breast cancer risk and it will actually decrease patients' occurrences. And oncologists support that in most cases, 99% of them. So I can always do testosterone in patients, and that should alleviate a large majority of their menopausal symptoms. But let's say they continue to have hot flashes or vaginal dryness to an extreme extent. Well, usually what I'll do is I'll do a local vaginal estrogen to fix that. But if the hot flashes can't be addressed and it's so debilitating, well, then maybe I would use that drug. But I have found clinically, I've never had to do something like that because testosterone has a slight conversion to estrogen, not in any terrible way, a very slight, but it can often address some of the hot flashes as well. And I often get enough relief without having to consider even going down that path. But if I have a patient who's really, but the key is we always want to treat patients uniquely. There are some women who have just such a tremendous fear of hormones that there's nothing I'm going to do to be able to educate them to get that over that. So in those cases, that might be an option too.
And I mean, we've heard a lot about, I think the book Estrogen Matters that came out in 2019 has spread the word about estrogen, but I don't know. It just seems, it's hard to get to the bottom of, but it seems like estrogen is not the cause of breast cancer.
No, and actually what's interesting is that you're finally seeing in some of the broader lay articles and the bigger societies that have been conventional and thinking and really poo-pooing hormones, they're all changing their tune now, because after they've really delved into the Women's Health Initiative and kind of just dissected it, the original message was completely wrong, number one. And number two, it was all designed to create fear and it was misplaced. And they're actually seeing now, even in this horrible product like the Premarin and Prem Pro, which we don't even use anymore because they're synthetic, that most experts don't use those. But even in Premarin, so if you went back and looked at the original data, it always showed a reduction in breast cancer risk, and nobody talked about it early on. And as they started even digging further, that risk became even more prominent, where that women, the longer they were on Premarin, the better their risk reduction from breast cancer became. And also what just recently in the last year, a publication came out that Premarin actually showed in those studies a 40% all-cause mortality and decreasing breast cancer in patients. And not even the aromatase inhibitors or all the drugs we use to treat breast cancer patients can show the same data. So we have totally given estrogen a completely bad rap when it comes to breast. And when you actually look at what drives breast cancers, it's inflammation and it's toxicities in the body. And it's not actually the good estrogen, estradiol. But when we become overweight, we convert that good estradiol to estrone, which is highly toxic estrogen. That's probably more of the culprit, not estradiol or the drugs that we typically, or the hormones we typically use. It's smoking, it's drinking, it's being overweight. Actually, when you look at the data, being a flight attendant confers more risk for breast cancer than actually any hormone ever will. And actually that's finally coming out to show that the Premarin has great protection on breast. So I think the next 5-10 years are going to be interesting to see what happens.
It reminds me of TikTok I saw today by a very famous OBGYN who was saying, someone was saying, what about plant-based hormone therapy, bioidentical? And she was saying it was basically a scam to call it that, and synthetic, because it's synthetic and synthetic is synthetic and they're the same thing. And right. So could you get at that? Because I'm seeing this more and more, and I'm wondering if it's drug company messaging, because I've seen a couple of doctors that's the third doctor on social media now that I've seen saying bioidentical isn't a medical term. It's not safer. Synthetic is, it's a bit odd to me. And the wording is similar that they're using. So that's why I'm a little bit like,
the way I
weird.
really look at it is that when you're looking at the hormones we replace, we should mimic the hormones that are going into our body. So the way I prefer it is actually, is it biomimetic, meaning is it identical to the hormone that our ovaries make? So 17 beta estradiol is what our ovary makes. That's what I should replace. Premarin is not 17 beta estradiol. Estrase cream, which is actually a commercially available drug made in pharmaceutical companies, is it bioidentical. Bival dot patch is bioidentical. My pellets that I provide are bioidentical, 17 beta estradiol. So the key is to find that product. Where I think the confusion comes in is that I can go to a compounding pharmacy and they can make me the bioidentical 17 beta estradiol. But there are also some products that are synthesized synthetic products in a pharmaceutical lab that are made to be exactly bioidentical. So I think people get into these semantics and they kind of throw different words around. And of course, putting something into someone's body that is bioidentical is going to be safer and better for them because their body recognizes it. I'm not going to throw a synthetic in that the body can't recognize itself, number one, and potentially not cause the clinical effect I'm looking for, and it may cause more side effects. So the key is to put something in that the body recognizes.
Okay. It seems like those messaging is targeting compounding pharmacies.
Well, of course it is,
because creating a ton of confusion for people.
Well, they want to get rid of that market because big pharma wants to keep their stronghold on the billion-dollar market that they're so far tapping, and compounding pharmacy is growing because it's providing more options and more specialized options for women. Because first off, there's not one testosterone available product that's FDA approved for women, so we have to go to compounding on that side. So they also, when you're on the commercial side, it's often much more expensive for patients. It can be cheaper in the compounding. And also I can highly hone it in for a woman tweaking things or dealing without like allergenic people who have those components. But the way I look at compounding and commercially available drugs is that imagine like the FDA approved products are like going to McDonald's and ordering a Big Mac. I mean, that's made for the masses. It's made exactly the same way every single time. If you want a Big Mac, go get a Big Mac. But if you want to go to a French restaurant and get a highly crafted and specialized meal, that's compounding pharmacy. And the big misnomer is that everybody thinks that compounding isn't FDA approved and it's unsafe. But here's what's interesting is the compounding pharmacies use the exact same ingredients that are frankly FDA approved, highly regulated. They're just specializing in creating little different ratios and tweaking it, but it's the same active ingredients that are being on those big agents. They're just made in one specific way. So all of it's FDA approved. One is just tweaked a little bit.
Yeah, but the FDA is not coming around and looking when they're mixing up the one little dose. They couldn't possibly.
No, and that's where it's really important to make sure that you're dealing with you're dealing with reputable pharmacies, but there's also different degrees. So for instance, there's 503A companies, which are like the mom and pops that you bring in a prescription, they fill that prescription and you go home. There's also 503Bs, which are highly regulated by the government that do mass production of different products and different things. So like pellets that doctors can dispense in their office. But the regulations on those, either 503As and the 503Bs are becoming so, like the 503Bs have always been heavily regulated. They're regulated to the degree of pharmaceutical companies. So they're not unsafe. And the 503As have now become so overly regulated that it is also incredibly safe. And a lot of the regulations that are being put in are knocking out these indirect mom and pop shops that don't really give high quality products. So that compounding space, in my opinion, is incredibly safe now. And I have no issues going to them. The key is I look at the whole universe of what I have available. At times I'll use the commercially available products. I like Iastrace cream in some patients, Vagifem vaginal is great for patients. And so there's products there that I enjoy using in my patients, but I also know that I need a lot of ability to specifically personalize something for my patients, and I can't get that in commercial.
And you talked about the squeeze that's being put on the pharmacy on the compounding pharmacy
yeah.
industry. I've
They
spoken
want
to
'em out.
yeah, I've spoken to the alliance, and it seems really unfair. I did it. That was one of the most
Incredibly unfair.
illuminating. Sorry?
It's incredibly unfair. And then when you look at the FDA in a large way, they are a mouthpiece for big pharma because most of the funding comes from big pharma. And you look at a lot of these big medical societies that also they're bought out by big pharma because most of their funding comes from them. So they're highly conflicted organizations that are working for companies that have a very unaltruistic desire to have the bottom line in meeting their shareholders. So unfortunately, that doesn't match up to doing the best for patients always. The whole system is designed to keep patients sick. It's not designed to keep people well. And the beauty of compounding is most patients can afford a lot of that stuff. Big pharma stuff, you can't. So, and it's because they have to go through the process. I saw it firsthand. They go through these patent processes. They have to do all these studies. They spend millions and millions of dollars. Of course, they want to protect their investment and get it back. So it's no wonder those drugs are so expensive. They have to be for farmers to survive.
But that's another lie too, because I've seen doctors saying you can get the commercial preparations much cheaper. Compounding is so expensive. Like that is nothing
further from the truth. Yep.
Wow.
Incredibly so. You look at, like, say, for instance, Bival dot patches, and depending on your insurance coverage, that could be up to like $150 to $200 a month. I can get an estrogen, say, pellet, and I mean, let's say I get like compounded cream for a patient, that could be like $30 to $50 a month. You know what I mean? Wow. It's just, and then there's creative ways. So if I have patients who are really struggling financially, you can double up the dose and have them take half of it. You know what I mean? So there's ways around that to make it more cost effective.
So is there a danger then over testosterone if the compounding industry gets squeezed? Would you have trouble getting testosterone then?
Absolutely. And that's why people should be pay attention, because again, this is where gender bias will bite us in the ass. If somehow compounding pharmacy gets shut down, which it would be hard to do, but they're trying, and the alliance keeps fighting and fighting and fighting. The problem is it's going to affect women specifically, not men, because men have all the products they need. Women don't. We don't have one FDA approved that testosterone product. So where do we go? We're going to be screwed. And so I encourage your audience to really pay attention. And there's an organization, the alliance that we keep referring to, that's really trying to fight to protect the right to still keep compounding available. And I can go to a website called compounds.com, and you can look and see what they're trying to do and put your personal stories. You can write to certain Congress people. You can also provide donations, but there's a huge effort going on to prevent that from happening. I know here in our state in Arizona and the United States, worked with a friend of mine who's a legislator, and we finally put together there was a bill we got passed, and we had a unanimous support from both Democrats and Republicans, if you can believe that, to basically protect the right to compound in the state of Arizona. We're the only state in the union that has that right now. And we need to facilitate that, because if the federal government decides to do something, at least here in Arizona, we will be able to get our compounds. And it was a huge win for us.
Well, this is crazy making. Like, I've been dreaming of a post, like all the things you think you know about compounding pharmacies that are not true. And it's like, they're expensive, they're dangerous, like there's just so many of these messaging. It's just messaging coming from drug companies who want to scare you off of it.
Yeah, exactly. Yeah. It's terrible.
So
I always ask, when you're getting a message, ask who's paying for it. Is there a conflict of interest? And you'll always get the answer.
Yep, I learned that in my early days of journalism as well.
I'm sure you did.
Who makes the money? Well, listen, it's been great talking to you. I'm so glad to connect. Thank you so much.
It's a delight to speak with you too, and happy Valentine's Day.
You too. Thanks. That was great.